Good morning, everyone. Welcome to our first seminar series from the National Centre for Antimicrobial Stewardship this year. We have a program that always covers a One Health focus. So throughout the year, you'll hear from speakers from the hospital sector, primary care, animal stream as well. Today, we have a focus on the hospital tertiary care. And I'm very pleased to welcome Dr. Gemma Reynolds, an AMS and ID physician, has many appointments, but primarily with Austin Health. So Gemma, please take it away.
Thank you, Courtney. Thank you for the opportunity to present today. And I'd like to acknowledge the Wurundjeri people of the Kulin Nation, the traditional custodians of the land on which I'm presenting from today, Austin Health in Melbourne, and pay my respects to their elders past, present and emerging. As Courtney mentioned, I'm an AMS and ID physician, medically leading AMS at the Austin. And I thought I might take the opportunity today to talk about what I think are some of the modern day challenges in hospital AMS and how, as a service, as physicians, as pharmacists, as nurse practitioners, we can reflect on these challenges and how we might build and change our services to accommodate them. So when I started in this role, was reading broadly around the topic of AMS, of course, and came across the three pillars, which we all know well, of how to run a successful hospital AMS program. And the CDC argues that it's this kind of synergy between the pre-authorization of antibiotics, so automating these processes so people don't have to think too hard about the antibiotics they're prescribing appropriately, engaging with teams in a prospective fashion, so there's antibiotic feedback, but also then feedback from the teams about their patients and their outcomes, and emerging and engage really closely in that service, and then institution-specific guidelines so that everyone has an understanding of the type of antimicrobials that should be used and the ways in which they should be used. And I'm very lucky to have come into a service, as I'm sure many of us are privileged to work in, that has all of these pillars in abundance, automated antibiotic approvals, be it through EPIC or guidance or ideas, a 24-hour hotline manned by our physicians and our registrars to give antibiotic advice, really well integrated AMS services into some of our big units like our hematology unit and our hepatobiliary unit and our ICU, and then what seems like a never-ending number of standards and protocols and guidelines that are frequently revised with the latest evidence to help us guide those appropriate antibiotic decisions. I think what happens, though, is as we build these pillars, there's natural tensions between them. So, for example, between the automation of antimicrobial stewardship and, curtailing antibiotic prescribing at the front end versus an integrated service where we're hearing from clinicians about the impact of these interventions, and it's a two-way conversation. There's a lot of tension between what is the most efficient approach, for example. The other way to look at it is we have a lot of guidelines that are built upon evidence and incorporate the latest clinical research, but we have a lot of audits and feedbacks and ways of evaluating our programs that don't necessarily focus on those metrics of patient outcomes. They focus on, say, 5 moments of antimicrobial stewardship and stops versus switches and IVs versus orals. So are we aligning the way we're auditing our service to produce the type of evidence that would inform those guidelines? And we also, can sit deeply within a unit and look at a patient 12 to 24 to 48 hours into a hospital admission. But are we really impacting frontline prescribers? Because that's falling in the domain of these pre-existing protocols or these automated processes. So I think there's a lot of natural conflicts that arise here, not to mention the demands on pharmacy and medical time, as we mentioned, patient outcomes, and then trying to avoid the stigma of policing and the stigma of prescribing etiquette when we are trying to influence the frontline prescribing. I think even as we work to overcome these challenges, more will emerge. For example, how are these amazing automated electronic services best delivered in regional and remote and community settings? How can we ensure the longevity of some of these well-integrated services when they are workforce dependent? And in frontline prescribing, we still have the kind of final frontier of the septic or the immunocompromised patients who we are learning, may benefit increasingly from stewardship, but are very hard patient population to effectively implement that. I think coupled with the challenges perhaps of delivering AMS service is this movement within the research for looking at shorter durations and the efficacy of that. So I think there's a natural evolution of evaluating AMS processes and AMS projects in a way that looks specifically at antibiotic duration, which is not necessarily how we have always done things. And I've just popped this slide together to show the absolute wealth of research that has underpinned, tuberculosis management and HIV/AIDS management. And antibiotic duration, and that concept of shorter is better, is a really new field. So 68 papers from a very quick search of PubMed since 2021. So I think even academically, there will be this pressure to explore the impacts of AMS interventions in this way. So what I wanted to do was to look at our end of 2023, start of 2024 interventions through this lens, through these, what I see as the challenges of AMS programs in tertiary settings. I thought I'd focus on something we'd failed at before, which was plastics, one of our final frontiers, which was oncology, and spinal medicine, which I think is going to illustrate a couple of those points about the longevity of service, integrating service, and developing your own evidence base. So I'll start with plastics because we failed before. I think plastics was attempted pre-pandemic, so maybe 2018 or 2019. And over a year of weekly meetings with the team to look at antimicrobial prescribing, it failed miserably. We had, less than a 50% acceptance rate, and 84% on the SNAPs were non-compliant with appropriate prescribing. So what did we do? Well, we picked our brightest and friendliest pharmacist. This is Ms. Danelli Pereira in the top, and we went in person, flexible times, court registrars in theatres and teams on the ward, lots of olive branches, lots of ad hoc medical reviews of hospital-acquired pneumonias and, line infections to help the team. And really looking at those big ticket items, really prolonged duration of IV antibiotics, inappropriately broad IV antibiotics, very sick patients that actually needed help. And for the 48 or 72 hours of IV cefazolin or the 3 days of Keflex on discharge, we kind of agreed to disagree in the short term because we wanted to focus on these bigger ticket items. And I have to say that approach, although labour intensive, was very successful. We had a much higher acceptance rate. We were able to optimise duration better than before. And when we asked for antibiotics to be stopped because the patient was clinically well, because the appropriate duration of prophylaxis had been met, we had a much higher acceptance of that discontinuation. So all in all, a successful service, but as mentioned, labour intensive from a medical and pharmacy personnel, and then the longevity of the service is something that we need to consider. From oncology is one of the final frontiers, so the immunocompromised patient. And we'd done this somewhat successfully in heme, so we applied the same model to oncology, which was to look at intravenous antibiotics for infections in oncology patients, to look at non-neutropenic fever, and to look at prophylaxis interventions, particularly with immunotherapy, concomitant steroids, and Bactrim prophylaxis, as we find this is an area that can be missed. Again, it was a twice weekly intervention that was pharmacy-led and a combination of in-person and Teams plus a Teams chat for additional advice. So very comprehensive, very integrated, but very time-consuming. And this is 3-month data. So we had 284 orders, making an AMS recommendation on about half of them. And 10% or so of those orders was around optimization, so the addition of prophylaxis for patients that warranted it. But as we can see from the table below, there was very high acceptance rate of stopping or switching to oral therapy, even in an immunocompromised hospitalised patient, which was great from a stewardship perspective. We could convert to ID referrals and help streamline the team quite easily. A narrowing spectrum was limited in the number of recommendations that we made, but widely accepted. So I think, again, it's a very was very successful program on those metrics, but it still has some problems. One is the kind of intensity of the intervention. The second is that it doesn't address frontline prescribers in both plastics and oncology. We're addressing 24 to 48 hours into the admission, even with a twice weekly round. And it's not contributing necessarily back to the evidence base to say that these types of infections in these types of patients have done well with X duration, and that X duration being shorter than what we would classically think to prescribe. So I think there's still a way to go with these services, especially in addressing frontline prescribing and the evidence base. So then I want to talk a little bit about AMS, because this is in spinal patients, my apologies, because this is a long running service and we have achieved some of the integration, I think, and influence on upfront and frontline prescribing in this cohort. So I wanted to talk you through it. First, I'd like to acknowledge again Mr. Nelly Pereira, who together with Prof Jason Triviano has led this service from 2017 until present. So a lot of the data here was before my time, and I give full acknowledgement to the team and the spinal unit at Austin Health for the really wonderful service that exists. The basic structure of the AMS round is the pharmacist will identify patients who've been on more than 24 hours of antibiotics, or then any oral antibiotics as well in the week, review the chart. We look at it from an AMS physicians as well, and then us and the spinal service with the spinal consultants present all join the same meeting on a Tuesday and discuss the list of patients presented by the spinal registrars. Infections are discussed and plans are made. This is complemented by a weekly in-person round that I do with the spinal team and the plastics team, with a specific focus on the pressure wounds, sacral and pelvic osteomyelitis, which I think need clinical review. So Janelle has published some of these outcomes, and the citation was on the previous slide, but to look at that pre-implementation, sorry, the baseline, the post-implementation, which was a year post, and the 3-year post-implementation, we had, 60 comparable number of patients across the time period, of comparable age and medical comorbidities. And interestingly, although not significant, the number of quadriplegic patients who have a higher severity, I think, of infectious complications, more difficulty with bladder care, more difficulty with ventilations, and more prone to pressure injuries is anecdotally, and this is shared by the spinal team, increasing. So an increased complexity of patients. When we looked at our, core AMS outcome, which was, did we reduce IV duration in this cohort? The answer was overwhelmingly yes. When we started, patients were on a median of a week of IV, and 3 years post-implementation, that's come down very consistently to 3 days, after which oral switch is made depending on the indication and the necessary duration. And we've seen that also with our secondary outcomes. So we have oral antimicrobial therapy. We use a lot of bioavailable oral antibiotics, for example, Bactrim for osteomyelitis. We might use Augmentin, for example, and we've able to reduce the total amount of therapy given to patients in the spinal cohort and their total duration of those orals as well. And this is exciting, I think, because of the frequency of infections in this cohort and how young people are, sadly, when they acquire their spinal cord injury. So multi-drug resistance and untreatable gram-negatives is a sad reality for many of these patients. So short course, oral, limited spectrum, I think, is very important from an antimicrobial stewardship perspective. We think we also influenced upfront prescribing, because when we looked at the number of patients each week on a round who were receiving antibiotics, this reduced over time. So it's a long-standing service. There's brilliant collaboration between the team, and we think there was an influence on upfront prescribing. When we look at our dot data, it's pretty nice. We should add 2022 and 2023 to it, to be honest. But we can see that the dot data is also reflective of the outcomes I just shared, and steadily decreasing kind of 3 years into intervention. When we looked at safety measures, I think this is important. We need to add this to the evaluation of were we able to curtail or narrow antibiotic prescribing. So we looked at hospital length of stay, and it was comparable at 3 years compared to baseline for patients with infection. We looked at recommencement of IV. So we were running everyone so short that they then needed to recommence their antibiotics, and the answer being no. That was statistically significantly lower at the 3-year post group. And readmission within 30 days is common in these patients because of the degree of comorbidity, but not different between baseline and 3 years. So I think from a safety metrics, there were no red flags that we were doing people harm. In terms of culture and practice and specific infections, which I think is important for reasons I'll discuss shortly when we talk about pelvic osteomyelitis, when we break down these numbers by the types of infections we commonly treated, we saw that, we know that the trend is to get shorter and narrower, but we're seeing that across a range of infections. So for skin and soft tissue infections, we're treating for 5 days instead of close to 2 weeks. For urinary tract infections, we're coming down from that 10 to 14 day for complex urinary tract to 7 days. And I actually think we're now closer to 3. So catheter change and 2 doses of antibiotics in a non-bacteremic stable patient who improves post their IDC change. Similarly, patients get a lot of prophylaxis around urinary procedures, around plastics procedures, and because of the comorbidities, and we're able to curtail that and do it in a much more streamlined fashion. I think the kind of culmination of all of this cultural change within spinal antimicrobial stewardship is really reflected in pelvic osteomyelitis. And I would also like to acknowledge upfront that this is multidisciplinary. This could not be achieved without the excellent wound CNC that exists within the spinal unit, the spinal consultants, the plastics team, who attend in person weekly for a consultant surgical opinion, which is pretty fantastic, and antibiotics on top of that. What has evolved over the 5 years is really this lovely model of care where patients are identified through these outreach services, with the CNC leading that for high-risk wounds in community. They're identified, brought into either outpatient or inpatient assessment. Antibiotics are typically not given for chronic wounds if the patient is well. There might be imaging, or often it's a clinical diagnosis with probe to bone of sacral and pelvic osteomyelitis. And then there's a planned surgical approach, which is initial debridement, for which we obtain our deep tissue and bone cultures. We then treat either skin and soft tissue or osteomyelitis using a short duration of IV and then primarily bioavailable orals. And the patient remains an inpatient for that 4 to 6 weeks of debridement, flap, and then a post-flap sitting program to prevent pressure injury to the flap, which is really important. And we're able to treat most of these infections from an antibiotics perspective for around 4 weeks only once there's been surgical debridement. And our predominant use of antibiotics is Bactrim and Augmentin. Now, when we audited some of our outcomes, and this is a small snapshot of this program published by our plastic surgery colleagues, in 93 patients, there were 45 flaps. So 45 patients went through this whole process, and at a 3-year post-surgical review, 5 had recurrence. And the expectation is that a flap would last somewhere around 5 years. So that's kind of considered a bit of a failure per se, 11% failure rate. When we compared this to the NHS data, and data in this area is very scant, I think these programs exist within their units, and we need to publish in an implementation sciences approach how we do work like this to inform the evidence base, to allow more groups to see and audit their own practices as well. When we're looking at the NHS, the failure rate was about 70%. So this is working. We are very happy with how it's doing as clinicians, but we haven't got much of this data out here in a holistic, multidisciplinary type format. So before I close for questions, I just wanted to say that I think if we take academics and clinical, service delivery in the sphere of AMS, I think the kind of piece de resistance is that we have these programs that are so embedded, long-standing and collaborative that we can then use them to generate an evidence base of how shorter durations or more targeted therapy is of benefit to patients, and that can be moved forward into informing policy and practice elsewhere. So thanks so much for the opportunity to present today, and we've got 10 minutes of questions. I'll just stop sharing my screen.
Thanks so much, Gemma. Fantastic presentation. I can see there's a lot of AMS pharmacists online too. So I'd like to open this up to the floor to give everyone else an opportunity to ask a question. Please raise your hand or use the Q&A functionality. But while we're waiting for anyone else to ask questions, I'll go first. So you've had multiple targets, so your spinal service and whatnot. Do you have any new potential areas on the horizon at the Austin, or is it more going back to one of the ones that you haven't had as much success with, or what do you think
No,
is next for you guys?
yeah, it's a great question. There are two that I would love to expand into. One is colorectal. As like Kaz and Michelle will be the first to tell us, there's an increasing complexity of colorectal surgeries for cancer. They have increasing infection rates associated with them and prolonged courses of antibiotic therapy. And I think integrating into the team, understanding the surgeries, understanding the windows for reoperation and things in particular is really critical to managing these patients with antibiotics. I would love to integrate part of the team with the colorectal service. And the second one is actually renal transplant patients, and their primary driver of readmission is urinary tract infections. So I think there's a lot of work that can be done there in optimizing antibiotic prescribing for outpatient urinary tract infections in transplant populations, and applying some of Julian Cousimont's work looking at not treating asymptomatic bacteria in these patients, and using that as a way to improve kind of patient outcomes and care. So they're probably the two big ticket items. We have a fantastic team, very blessed to work with the group that I do, but we need slightly more woman power before we roll some of those out
Yeah.
this year.
Oh, excellent. I guess then my other question was, or no one else has asked anything, the outcome metrics. So I think it was on the spinal slides where you had the outcome metrics of the length of stay and restarting IV and use. Was that stuff that was in the literature specifically for spinal, or stewardship, or just general AMS? And then, because Austin has Cerner, so was that requiring a lot of manipulation of data out of Cerner to get those sort of metrics? And I guess a bit of insight on how you got to that and used your EMR system to get those outcomes, because I know a lot of AMS programs, they want to give that outcome data, but getting it isn't always the easiest thing. So
100%, right? Because all of our electronic systems, as you say, download the prescribing data and the changes and not readmissions, ICU and patient care. I think Epic probably has much better potential to automate this than Cerner. We use business analytics unit to request extractions, which is, the whole hospital wants that data, right? So you're in a queue appropriately to try and access it, or you manually collect it. So a lot of that data was collected manually, which is time consuming. How we picked the outcomes, it's really inspired by people like Kasha Singh, who published on the plastics AMS work at RMH and said, hey, actually, we had a high rate of infections in some of these groups. And so it was wanting to check that what we were doing was safe. That's really kind of what inspired looking at those kind of outcomes. How we will do it in the future, I think, is prospectively collect these patients. Because we're already writing in the medical records, we're already clinically involved and seeing them, and it is easy to then take that data across contemporaneously and save that retrospective data trawl.
excellent. Thanks so much, Gemma. Nothing from anyone online, and that's okay. I mean, if something comes up, we can always have a discussion at the end, and that's what the chat functionality and the QA functionality is for. I'd now like to introduce you to Dr. Michelle Yong, who's also an ID physician, but her role is based at the National Centre for Infections in Cancer, PEDM. And Michelle, I'll let you share your screen.
It's sharing. I'll just put it.
Yeah.
Is that kind of?
It's not in presenter mode yet.
Yeah.
Yep, now it is. Perfect.
Okay. All right. Lovely. Thank you, Courtney. And thanks for the invitation to speak to you all. This is really exciting. I'm going to be talking about antiviral stewardship in transplantation. And I've provocatively called it the next frontier, as we are hoping to learn a lot from antimicrobial stewardship and then antifungal stewardship. My interest is in optimizing antivirals in this population. So I have NCAS to thank for this wonderful figure and demonstrating to really the public view what are antimicrobials, and wanted to highlight the antiviral section. And it points out that antivirals are used in the treatment or prevention of infections caused by viruses, and that many viral infections are mild and often do not require any antimicrobial treatment. And that's true for the general population. In fact, we're trying to say that viral infections don't require antibiotics, but because I work in the area of immune-compromised hosts and in particular transplantation, these so-called the sort of mild viruses, whether you call them common cold, flu, chickenpox, or shingles, can have very devastating and very severe effect in those particular hosts. And so we want to get the antivirals initiated quickly and optimally for good outcomes. So it segues into sort of targeting probably the most common virus in the transplant population, and I work particularly with cytomegalovirus. And by way of background, this is a human herpes virus, which is transmitted often when we're a young adult through routes such as saliva, placental breastfeeding, or sexual contact, but also through transplantation, be that primary transmission or by reactivation of past infection, as the virus is able to remain within our mononuclear cells and can reactivate and cause difficulty. And the most well-recognised group is in the transplant population. So it's an easy target. It's the most frequent virus, and pleasingly, and many transplant units have protocols, and it depends on whether you're transplanting a kidney or a heart, lung, or stem cells. There are international societal sort of guidelines that can be followed, which are sometimes adapted into sort of institutional protocols. But in order to run a transplant program, there are often CMV guidelines within institutions. However, what is the problem in particular that CMV infection causes, and why is it important to get it right? Well, CMV infection, if uncontrolled, leads to high mortality and high morbidity. And this is even despite all modern care, ICU supports, and good molecular techniques for diagnosis. And in particular, just want to highlight some challenges with CMV antiviral prescribing. So often the prescribing is done within specialised units who have been doing this for a long time, and often it's both inpatient and outpatient. They're, however, sometimes often commenced as an inpatient, and these patients are highly comorbid and very complex patients. In particular, say the allotransplant group, they often have not a neutrophil to their name, often with fevers contributed by probably multiple different causes, with renal impairment, liver impairment, and multi-organ dysfunction. Unlike antimicrobials, there's often long durations of therapy, and often in a recurrent way as well, sometimes requiring up to 3 or 4 different courses of treatment. So long duration of treatment on average about 3 to 4 weeks, sometimes much longer. And I think I've had someone roughly on about 181 days of anti-CMV treatment. We have to be aware of drug toxicity, in particular effects on the bone marrow and on the kidney, drug-drug interactions. And when we talk about optimized prescribing, there's always the issue of drug resistance, and that certainly occurs in suboptimal use of antivirals with CMV. And I'll talk about this later, but there's a couple of new drugs that are coming out into this field, and with that comes expense. But not only with the drugs, if we don't treat it correctly, CMV also causes a lot of prolonged hospitalisation, and we know through some of the work done at Royal Melbourne that, people with CMV infection spend up to a month longer in hospital. The problem isn't also directly in front of you with regards to just the pathogen. Again, I postulate that if we don't optimize treatment of antivirals, there are sort of some indirect CMV immodulatory sort of effects which persist following treatment or in conjunction with treatment with the virus. And these include some really good data showing that CMV infection relates to non-relapse mortality, the consequences of treatment-associated toxicities such as long-term neutropenia, bone marrow failure, the effects on long-term kidneys, the effects on the allograft itself, secondary infections, and I've characterised secondary fungal infections in this group. As I mentioned before, the impact this has on hospitals with an additional 28 days of hospitalisation. And I've also done some work to show that people with CMV infection, even 2 years later down the track, have some impacts on quality of life, such as fatigue and social functioning. It's not only CMV that affects the transplant population, but this is a figure here, stacked bar graph and a Venn diagram to show you that CMV often, and what I teach registrars, if there's one virus, if patients are at risk of one virus, they're often at risk of 2, 3, 4, and up to 6 different viruses. So when we looked at 430 allotransplant patients, we really documented that 90% of these patients had 2 or more viruses detected within the first year of their transplant. So there's certainly a lot of work and a lot of burden in this population. So over the last couple of years, this the concept of antiviral stewardship has really taken off, and so we're at the frontier of this. So I recently wrote an editorial called, Antiviral Stewardship, particularly in transplantation, given that we have whole new drugs coming out, so letimavir. How do we find a good place for maribavir? And also importantly, how do we preserve our old antivirals and use them safely and optimally so that we don't have to use our second or third line antivirals? There's some more recent work being done on ganciclovir levels, and also my other interest is not only monitoring the pathogen, but monitoring the immune system to help guide optimal duration of antivirals. But interestingly, even I was doing the literature search for this talk, and even on the 8th of February, in the Journal of Heart and Lung Transplantation, an article called "A Call for CMV Stewardship Initiatives in Cardiothoracic Transplant." And probably the most work has been done by Margaret Jorgensen, and they've published a really sort of series of work called CMV Antiviral Stewardship in Solid Organ Transplant Recipients, and called it the new gold standard. So why is antiviral stewardship important? Well, I hope I've sort of in the background told you that there's such high burden in this population, and that the treatment of it impacts not only on the underlying disease, but also the immune modulatory effects of these patients on the allograft long term. We're always discovering new at-risk groups as well. So the other big at-risk group are multiple lines of chemotherapy coming up to a transplant, and I often get asked about what to do there. There's also patients on alemtuzumab and other new agents, dasatinib, where CMV is particularly troublesome. If we don't get it right, we have to deal with antiviral CMV resistance, and that then has consequences of second, third, or combination therapy, and with that exponential increase in toxicity and expense. Unlike antimicrobials, we really have limited treatment options and limited tolerable treatment options. There's high cost of management, which I've talked about, high adverse events in these groups, particularly neutropenia. And the other sort of novelty in this space is potentially incorporating immune monitoring into the stewardship program to help guide things. So with regards to antiviral stewardship, this is a slide courtesy of Monica Slavin, who talks a lot about antifungal stewardship. And I thought I'd go through some of the comparing and contrasting with traditional antibacterial stewardship. So the specialties and the patients involved, we really need key input from the stakeholders and embeddedness of stewardship practices. And perhaps what I found is that the key clinicians in this group don't really like to call it stewardship. So there is a perception problem with stewardship. So working within the key groups, so the hematologists, the hematology pharmacists, the transplant coordinators, the people, clinicians looking after the post-transplant care. And it probably stems from a lot of acute care, but then later on in the transplant, liaising with regional care and their primary carers thereafter. The indications to commence antiviral stewardship is also a little bit different to antibacterial. So there's the concept of primary prophylaxis, treating before the virus has occurred, preemptive indication once the virus has occurred but disease hasn't. Of course, CMV treatment of disease, and often involving higher doses of antivirals. And then one of the things I spend a lot of my time doing is guiding on secondary prophylaxis. And these are patients who have had treatment, but due to their ongoing immunosuppression and ongoing complications post-transplant, can have very, very prolonged secondary prophylaxis courses up to a year or longer after. So there's sort of some of the difficulties, but on the other hand, really pleasingly, our pathogen diagnostics is very easy. So we have very true and easy molecular diagnostics, so a quantitative PCR, and that's often done twice a week, and most transplant centres will perform this, if not at least once a week. So finding the pathogen is easy, in contrast to antifungal stewardship, where the pathogen diagnostics is quite hard. As I've mentioned before, that when we think about antivirals, the duration is really quite prolonged. It's not a 10-day course or a 2-week course, and often we can't predict it at the time because it's dynamic depending on the immunosuppressive wean. And even after all these years working with CMV, I am unable to predict whether the CMV viremia is going to last 2 weeks, 3 weeks, or I've also been surprised at 26 or 52 weeks of viremia. And this often requires prolonged and recurrent courses. So we may stop, continue monitoring, but may need to restart antivirals within a month or 2 months after stopping as well. We have fewer agents, but can I say, particularly in the stem cell transplant group, that toxicities make a really important part of what we can use and really limits the options that we have. And whether it's toxicity from the antiviral per se, or intolerance because of their underlying immunosuppression or underlying poor graft function, really limits what we can use. And therefore, if we don't have those options, there's high cost. And the other difference is some of these antivirals, they're not restricted. They're able to be prescribed. It's often done in an outpatient fashion, and often at that stage not a priority. So I've done a lot of work with stopping sort of dose reduction unnecessarily. So I don't have to talk to this audience about what are the goals of stewardship, but just to say that they really are very, very nicely aligned with all the other stewardship programs. And we all want to improve patient outcomes, reduce adverse events, very much ensure cost-effective therapy, and very much want to conserve the use of our antivirals because there is not a lot in the way of up-and-coming new antivirals in this space. So with regards to CMV, what are the antivirals I am talking about? So on the left-hand side, we have our old familiar friends who we've used for a very long time, the ganciclovir, oral valve ganciclovir, foscarnet, and cidofovir. And recently, some literature and some evidence to look at letermovir in the primary prophylaxis space and maribavir for resistant refractory CMV. So although they're nicely defined in the studies, randomized studies, when you interpret that into the real world, we all know that it can be interpreted in a few different ways. And so my role is to ensure that we're all talking the same language when we're thinking about resistant refractory CMV. This is just a quick slide to demonstrate that those who have CMV infection over time have a 52% increase in total hospitalisation cost. So compared to those without CMV. So antiviral stewardship programs aren't new, but and so what other programs have been used for many years in sort of the antiviral space in the HIV population. There's been some literature of ribavirin in the RSV population in pediatrics, and of course in the last couple of years the appropriate and restricted or optimized use of Paxlovid for SARS-CoV-2 positive patients is a type of antiviral program. So there have only been 2 studies of targeted CMV antiviral stewardship in the solid organ transplantation and none in the allo stem cell group transplantation. So I'm just going to talk about what we have been doing at the Royal Melbourne and Peter MacCallum for quite a number of years now, of which we're trying to formalise. So the background to the antiviral activities dates back to about 2017, 2018, where a couple of key clinical problems were identified. And it was great because it came from both sides, both the bone marrow unit and also the ID consultants. And the first low-hanging fruit that was identified, that communication of results and availability of results between the clinician and the laboratory was suboptimal. So the fact that patients would come in on a late Tuesday, and they wouldn't get a result till Friday afternoon, or even if they missed the run of the CMV PCR, they wouldn't get a result for the following week. So that was one of the impetus to start sort of this antiviral stewardship interventions. The transplant unit here was also seeing a growing and a high-risk population for those at risk of CMV. So umbilical cord transplantation and haploidentical transplantation, particularly haplos, was starting to grow. And we knew from other parts of the world that CMV was at high risk in this group. There were a couple of difficult CMV resistant cases which sparked this interest as well, and resulting in a lot of inpatient hospital stay and different conundrums along the way, which we thought we could better streamline. And we also had a number of really interesting clinical studies, which also, as an offshoot, was an indirect benefit of having a problem, having a intervention which we could then identify new patients eligible for study. So we commenced a weekly CMV meeting, which was initially face-to-face, and it piggybacked off a clinical meetings. So there was already a cohort of all the right people in the room. So all the allo transplant clinicians were there, nurse practitioners, particularly those in the post transplant care. There was ID physicians already there, the heme registrars, BMT pharmacists, and transfusion staff. So every week we meet and we have around 50 to 60 participants, which is a really big number, and individual patients are reviewed and discussed. So first of all, we review all the CMV viral loads for the week, including in particular those which are missing and negative. And they're the ones that we then say, hey, so-and-so hasn't had a viral load, and we action that with calling up ICU or finding out what's going on and how come that was missed, because those missed viral loads were sometimes 2 weeks later the ones who ended up having viral loads in the millions, and we've sort of missed that opportunity in that monitoring period. The meeting is also really great for discussing the concurrent immunosuppression as well as what's going on with the virus. So a clinician may say, well, this patient's got graft versus host disease. I'm going to hit them with high dose methylprednisolone. So even though the CMV is only considered sort of mild or under 1,000 units per mil at the moment, we can predict that in 1 week or 2 weeks' time, it's going to go through the roof. So let's think about starting antivirals at that stage. We review the individual risk categories. So in that instance, say someone started on a lower dose prednisolone, we look at the if they were a CMV neg-neg or CMV pos-pos, or depending on their risk category, we say, well, perhaps in that patient with a lower risk category, we can just watch and wait and wean down the immunosuppression. We come to a consensus about threshold for treatment, and then we also agree upon a choice of antiviral. So be it an oral agent, whether they need to come in to hospital to get an IV agent. And we also decide whether it is most appropriate to use, again, cyclovir-based regimen or foscarnet. So these are some of the descriptive outcomes so far. And overall, it's been successful for really improving communication between specialties, between ID, micro, heme, BMT and ICU. It's been fabulous for that. And not only between specialties, but between craft groups as well. So really great involvement from nursing, pharmacy, and also research staff, and like I said, transfusion staff as well. We've been able to early identify at-risk patients, start antivirals more appropriately. We discuss neutropenia earlier. So so-and-so's neutropenia is dropping. Shall we start GCSF, or can we wind back some of the immunosuppression, or could we stop the valganciclovir and switch over to foscarnet? The nursing staff really like it because it really helps with planning of admissions, and also the patients like it. So although we see them on a Monday and we've got a rising CMV viral load, we discuss these patients on a Wednesday, and then we can then update not only the inpatient unit, but the patient, hey, look, if it's up tomorrow, you'll need to come into hospital. But if it comes down, we can continue the same way. Like I said, we've identified lots of research participants, and it's good to quantify this. And it's now sort of expanded into other difficult viruses, such as EBV. So we have a CMV list and also an EBV side line. And we also discuss other difficulties. So we've had some JC virus and also more recently some really difficult HSV viruses. And in this space, it's not only about the drug, but we use other forms of therapy such as T-cell or adoptive T-cell therapies. And we discuss this in conjunction with the antivirals. So the ongoing progress with this program is really, we want to aim to formalise it and to evaluate the therapeutic management before and after the introduction of this CMV meeting that we've been running for some time. And to do this, I plan on doing a retrospective pre and post intervention cohort study. And I'm really pleased to say that that Violet, a pharmacist here, is really interested in this program and is going to help out. And our outcomes of interest are some of the CMV related things. So obviously incidence rate of CMV resistance, rate of CMV disease, rate of prescribing, appropriateness of antiviral prescribing following AMS sort of the values and what we do here, the time to appropriate antivirals and CMV related hospitalizations, but also hoping to get to sort of maybe quantitate some of that nuance of or action items when we look at discussing intercurrent immunosuppression as well. A bit harder to capture. So just as a couple of more slides just to say what else is happening in this space. And when I talked about that gold standard is very similar to what we've run. I think each institution needs to adapt to their the local sort of environment and what's been happening in this space. So this antiviral stewardship program occurred in a kidney and liver transplant group. And again, they identified a couple of problems and they went through and commenced a stewardship based on guidelines. And all of the key things about this are that they have to be multi-disciplinary and to have sort of buy-in. Some of the things they learned and which we can take as well is that really using EMR alerts doesn't work in this area. So sometimes we're reviewing like 50 or 60 different patients. So to get alerts, it would send your inbox crazy. And we know that we're also having alert of fatigue as well. So it resulted in overwhelming workload. So then they concentrated on one particular group within that transplant group rather than all patients group. And they identified this as having the highest risk for CMV and complications. They also had issues with local laboratories. So interesting that they were able to look at reporting times, standardize that, and look at problems with delay. And they also incorporated this cell-mediated immunity into their program, which is really novel and interesting. And they had descriptive outcomes. So they reviewed over 1,000 sort of different episodes and saw reduction in ganciclovir resistant, more streamlined care and reduction of CMV treatments. So I just want to wrap up with my concluding slide that antiviral stewardship is relatively new in the next frontier, that there are a lot of research and implementation opportunities. So I welcome anyone interested in this space to contact me. There's lots we can do here. There is a really targeted and captivated population, and as transplants get trickier and more high risk, so do the opportunistic infections. So my aims are really to currently evaluate the activities that we do in this precinct here to formalise the program. And really the big vision is to expand it into other transplant populations. When I've given this talk to transplant groups, they're quite envious of how we've managed to get everyone in the room and talk about this one virus. So it's been great. The vision is also to incorporate novel aspects and to understand CMV specific immunity, and also to look at therapeutic drug monitoring, particularly in patients who may be regional, and the use of dried spot blood monitoring. And the most interesting thing is how these new antivirals will fit into this space. We don't have them regularly available, but there is, as with all new antivirals, the introduction of creep, and we will be seeing these in this space, and it's important to understand where and how they fit. So thank you very much.
Thank you so much, Michelle. It's very exciting to hear about all the things that are happening in that space. But I mean, yeah, like it didn't just happen overnight. It's been many, many years of work in the process.
Thanks for that acknowledgement, Courtney. Yeah, and as we all know, sometimes it's sort of breaking down breaking down a lot of barriers and it being embedded in different programs.
Absolutely. Well, anyone else it's very welcome and free to ask any questions. You can raise your hand and I can give you the functionality to speak. But I'll ask some questions whilst we're waiting. In terms of the ward round service that you were running, Michelle, or the meeting, how many patients would you normally see, and like in terms of a time frame, how long would that normally take?
Yeah, so it's very tight. It's only runs over honestly about 10 minutes, and it's bang, 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 bang. And we could talk for ages being ID clinicians, but it is, we would go through, I would say, about 40 post-allo transplant patients. Most of them are fine. It's just negative, not detected, not detected. And the transplant nurses are really good. They'll highlight, they'll stop, and we might spend 5 minutes on one patient, one tricky patient. And if we do this, we do this every week, and a lot can happen in a week. With this, they've ended up in hospital and other things, but it's taken a while, but we can get it down to about a good quality 10 to 15 minutes.
Wow. And are you finding the issue, like, I guess, what is the issue, that they're just not getting that viral level done, or they need to be on something and they shouldn't, like they're not on it, or is it that they're on something but it's not right?
Yeah.
Like, where is the sort of key target there?
So the baseline work is putting the viral load into this meeting and ensuring that's done. So that's without that, we won't know what's happening. But I think the main thing we really discuss between us all are the viral load is going up. What should we start? How should we start it? And should they come in is sort of one of the key things. The other key is the viral load's not coming down. They're running into trouble. Their neutrophils are dropping. Should we apply for Maribavir? Should we get some T cells happening? And what are we doing with immunosuppression? So all of those things are quite complex, but and that's why I think it does work well in a real-time meeting. When we've tried to do this before with emailing, it just gets messy.
Yeah, I can definitely agree. The email thread just very
It's
hard to keep tabs on.
not good
Yeah,
use of time, and they're not inpatient, so it's unlike the sort of AMS rounds. We can sort of go around and talk about them. A lot of them are outpatients.
Yeah, and I guess that's like what makes part of that program even more novel too, because it's getting them in hospital earlier, and you see those benefits. So the outcomes from your cohort study will be fabulous to see when
it will
gets
be.
done.
Yeah.
And then just in the interest of time, so it is 9:29. But how are you going with that study? Have you got your ethics? Have you where are you
Yes,
at with that
I know.
study?
It's been discussed for a long time. We should formalize it. Let's look at the outcomes. But it does take a lot of work. So it's gone to sponsorship. It's going to get ethics. It's all a retrospective study, and we're starting data collecting.
Fantastic. Oh, well, thank you both, Michelle and Gemma, for joining us today. And I do apologise on Kaz's behalf. She had planned to attend, but had to sneak away to Sydney for a Department of Health meeting. So she sends her apologies and will be back on board for next month. But yeah, thank you both. For our audience, please reach out to Michelle and Gemma if you do have any additional questions. If you're interested in how to set up, targeted bespoke services in your settings. Obviously, it's never going to be a black and white copy and paste. Every setting's so different, but these are our experts here that you can reach out to. So we're very appreciative of your time this morning. And with that, I'll stop the recording. I'll have it up online for those to look back on later on. And we'll see you all in March. We'll have Dr. Ian Abbott and Dr. Louise Cooley presenting on microbiology and diagnostics, but at a more practical, applicable level for us on the ground floor of the wards each day. So thanks so much, everyone.
Thanks again. Bye, guys.
Bye.
Bye.